Greetings and welcome to Hangouts with HIVE. Today's topic is, who is using PrEP in the United States? My name is Yamini Oseguera-Bhatnagar, and I'm the Power Health Coordinator at HIVE, which is a hub for positive reproductive and sexual health. It's the 18th of September in 2018, and I'm broadcasting live from San Francisco. A little bit about HIVE. Since 1989, HIVE, which was formerly the Bay Area Perinatal AIDS Center, or BAPAC, has provided preconception and prenatal care to women and couples affected by HIV. Since 2005, all babies born in San Francisco have been free of HIV. Our mission is advancing reproductive and sexual wellness for individuals, families, and communities affected by HIV in San Francisco and beyond. And our vision is a world where people affected by HIV have safe pregnancies, reproductive autonomy, access to state-of-the-art healthcare, and enjoyable sex lives. A little bit about Hangouts with HIVE. Hangouts began in November 2015 as a way to learn and share the good work of innovative advocates and providers, such as the ones we are joined by today, with a commitment to HIV prevention. Since 2015, Hangouts has featured the vision and work of over 60 champions from all over the US. In 2018, Hangouts is taking a closer look at the reasons for HIV acquisition among women. We'll be thinking and talking about the ways women may or may not engage in healthcare, manage competing priorities, navigate systems like criminal justice, social services, and child welfare, and are impacted by structural racism. We hope to learn together with our panelists and viewers to shift our practice to better serve people, women in particular. So just a little bit on today's topic. So while PrEP uptake data are available from sources including AIDSVu and Gilead, these data sets appear to be different. And in order to build and improve and sustain PrEP programs nationwide, we need current and accurate data on who is and who isn't using PrEP. Today, we're going to try to answer the following questions. Which data do we use? What do we need to know about the different methodologies used to gather this data? How do we address the communications challenges posed by the different estimates provided to us? As we're listening and learning from our panelists today, let's think about our own work. How do the data affect your work locally? What data set makes more sense to you? And what are the gaps in the data? Some quick logistics for viewers before we begin. We're going to be on air for another hour. During this time, as you listen to our panelists, please think about questions that you have of their presentation and of their discussion, and ask it in one of two ways. One is via the comments section on the YouTube page, and the other is to text 415-842-2722. And if you like what you're hearing, or you want to share the love on Twitter, we're going to be using the hashtags, #Hangouts with HIVE and #US PrEP users. So join us on Twitter. So if you missed this live broadcast and are watching after watching the recording, go ahead and click on the link in the comments section to be directed to a list of resources that have to do with the content of this Hangout. Today's discussion will include a presentation followed by a conversation between our panelists. We'll then have time for audience Q&A at the end. And without further ado, here are our superstar panelists for the day. Let's start with Jim. Jim Pickett is an advocate specializing in new prevention technologies, gay men's health, social marketing, organizing, and mobilizing communities. He's the co-founder of International Rectal Microbicide Advocates. He directs Chicago's award-winning PrEP for Love campaign and leads the Illinois PrEP Working Group. Jim, super happy to have you. Ifeoma Udoh. Dr. Udoh is a senior evaluation advisor with extensive experience in implementing international and domestic HIV/AIDS programming and monitoring and evaluation activities in low-resource settings around the world, including the Caribbean, Asia, and the United States. Ife's interests lay in the use of community-based participatory approaches in behavioral and clinical interventions to address the structural impediments to accessing HIV prevention, care, and treatment. Ife was the director for Oakland's CRUSH project, a multi-year demonstration study to evaluate the expansion of PrEP services in the East Bay. The CRUSH Clinic was the first clinic in the Oakland East Bay area to extend PrEP to young people between the ages of 18 to 29 at risk for HIV acquisition. Ife, super happy to have you. Erin Siegler to our left. Erin is an associate professor in the Department of Behavioral Sciences and Health Education at Emory University. He serves as the assistant director of the Emory CFAR Prevention Sciences Core. His research explores the intersection of the biomedical and behavioral realms with a focus on sexual minority populations and disparities in healthcare. His current work explores issues of how to scale up provision of pre-exposure prophylaxis, how to increase condom use through innovating the condom itself, geospatial analyses to better understand access to healthcare, and exploring novel combination HIV prevention strategies. Thank you, Erin. While we're on your screen, let's go ahead and introduce Patrick. Hi, Patrick, to our right. Dr. Patrick Sullivan is a professor of epidemiology at Emory's Rollins School of Public Health and also serves as the co-director of Prevention Sciences Core at Emory's Center for AIDS Research. He has spent 24 years investigating HIV, much of it at the Centers for Disease Control and Prevention. Welcome, Patrick and Erin. And last but certainly not least, we got Matthew Rose, who is a policy and advocacy manager for National Minority AIDS Council, also known as NMAC, and the Community Working Group co-chair for Microbicide Trial Network. As policy and advocacy manager, Matt supports and works to develop and implement policy positions on federal appropriations and legislation related to HIV/AIDS and health disparities. He translates legislative findings into language the rest of the community understands. Very important work. He provides mobilization and technical expertise for the HIV community and external partners, particularly around the intersections of HIV, health, and race. He works in partnership with organizations and coalitions to further NMAC's legislative and public policy agenda, and also oversees the program development for NMAC's National HIV Biomedical Prevention Center. Thank you, Matt, for joining us. I'm out of breath, and that's a good thing because this is a super smart panel. All right. With that, what I'm going to do is, first of all, thank you all for joining us. And I will hand over to Erin and Patrick to share with us their data, their work, their baby AIDSVu, and then we will discuss findings.
Great. Thank you so much, and thanks for the opportunity to come and talk about the PrEP data that we have on AIDSVu. AIDSVu is a site that we really have with the mission to essentially share data that can help change the course of the epidemic. And so a recent addition this year has been data on PrEP use. So in March this year, AIDSVu released the first ever interactive maps visualizing PrEP use by age and sex. And we call this PrEP prevalence. And part of the reason that we did this is because there are all kinds of people, including advocates, including policymakers and program people, who would benefit from understanding the relative uptake, like what's the level of PrEP uptake in a state or in a jurisdiction, and how does that compare to other states? And when we released this, we also released a deeper look page, and these deeper look pages sort of provide a space where we pull together all the information that we have on AIDSVu about PrEP. So we have infographics, we have a PrEP locator, we have data on PrEP that are downloadable, and all that's pulled together in one place. And it's important to say that the data that we're presenting on AIDSVu really had to comply with sort of our sort of working rules for AIDSVu, which is that we display data that are substantially population-based and that can be updated over time, and that can be compared state to state because similar methods are used to develop these estimates at different levels of jurisdiction. So I'll talk a little bit about the data that we have available and then where the data come from and some of its limitations. So we have state-level maps and data sets that include the number of PrEP users in the data set and the rate of PrEP use, which we also call PrEP prevalence. And that's the prevalence or the rate measure essentially adjusts for the number of people in the state in that category. So having 100 PrEP users in one state might reflect a substantially different level of coverage than having 100 PrEP users in another state. And so that rate takes into account how big the state is. We have data every year from 2012 to 2016. We'll be adding 2017 this fall, which I'll mention later. We display the data overall and by sex and by age. And they can be displayed alongside social determinants of health. So we know that part of understanding PrEP uptake is understanding the larger sort of structural and societal factors that shape the extent to which PrEP is used. And those include things like health insurance, education, income inequality, and poverty. And so that you can sort of compare those side by side with levels of PrEP uptake. We also have another data set that is at the zip 3 level. So this is our zip code here in Atlanta is at where we work is 30322. So the 303 zip 3 level data would include 30322 and every other 5-digit zip code that starts with 303. So that gets to a smaller level than the state. And AIDSVu also has a PrEP locator, which is based on Aaron's excellent work in developing a national directory of PrEP providers. So I won't. I just want to give you a sense of where these data come from. And one of the things that I think is important about this is that the data come from Source Healthcare Analytics, which is a company that that gets data on prescriptions and makes them available as a data service, essentially. And so here, Gilead Sciences has an agreement with Source Healthcare Analytics. And so with Gilead's support, we developed a data sharing agreement that allows the data on to be not just used for analytic purposes, but actually shared in the granular form that you see it with anybody who wants to use it. The data come from a sample of over 54,000 pharmacies, hospitals, outpatient facilities, and 80,000 physician practices in the US. And so this is a large representation of the Truvada, which is being sold in the US, but it does exclude some entities that don't make their data available. And this includes closed healthcare systems, health maintenance organizations that have their own pharmacies and use those data internally, but don't share it with this kind of service, and any other entities that don't share their data. The data that are used for this contains information about prescriptions, but also other kinds of information like medical and hospital claims, and that helps us to distinguish when there's a prescription for Truvada. Is that a PrEP prescription, or is that being used for something else, like off-label therapy for chronic hepatitis B infection? But it's important to say that the data include prescriptions for all payment types. So whether people pay with cash, with Medicare, with Medicaid, commercial plans, the Gilead Assistance Program, all those are included. We don't get any information about people's identity, but rather we get data that are linked to data from the medical insurance claims, so we can make this decision about whether an individual Truvada prescription is or is not a PrEP prescription. And then we use an algorithm that's been validated to exclude use for HIV treatment, for post-exposure prophylaxis, or for treatment of chronic hepatitis B. It's important to remember that there is no single entity or data source that collects information on all the users of PrEP in the US. And so in AIDSVu, what we've tried to do is generate an estimate that it really is a minimum estimate, because we know some kinds of healthcare providers aren't included in the data that we have available to us. So we call it a minimum estimate. There are certainly more than the numbers that we estimate. And one of the things that's important for us was that we be able to provide it at smaller geographic units. So we currently have state and zip 3. We're going to be moving to put out county level estimates later in the year. And that's because public health, from a public health perspective, knowing a national number is important, but knowing what it is in my state or knowing what it is in the counties that make up my metro area really put me much closer to being able to take public health action. It's important to say that these data are raw in the sense that we know that there are certain prescriptions missing from our database. And for the purpose that we want, which is that we want to do this consistently, we want them to be comparable across states, we want it to be replicable, we want it to be available at smaller geographic levels, that we've chosen just to display those prescriptions that we feel confident represent PrEP, even knowing that we have some number of prescriptions that we don't capture, and I'll talk about other sources of uncertainty. But that means that this is a minimum estimate. It's useful if you, for example, we compare between states to see which states are doing better with uptake. Aaron will talk a little bit about this. And it's great for that purpose where the absolute number of users isn't so critical, but the comparability across states is important. Comparability between prescriptions for men and women is important. Comparability across age groups is important. And so these data are used for public health research for planning purposes, but they don't represent the total number of people who are taking PrEP. Rather, they're a minimum estimate that we can produce consistently. We can make conclusions, though, important conclusions, like this one, which is one of our findings is displayed on AIDSVu, which is in 2016, 93% of all PrEP users were male. And looking at this period from 2012 to 2016, the number of male PrEP users increased 95%, nearly doubled year over year during that period. And so at the end of this time, the rate of PrEP use was more than 14 times higher for men than for women in 2016. So this really points out a difference in use by men and women, that we can make these comparisons and look at trends over time, even though we know that each individual number is a minimum estimate. It's consistent across time, so the projection of trends is still valid. I also just want to point out that these data are published in a paper in the Annals of Epidemiology. It's available open source. We can send out the link to it. But one of the things that we did was we wanted to sort of try and at least illustrate this idea that we think we have a minimum number of users, of PrEP users, and that there are reasons to think that it's higher. So for example, in 2017, we estimated in our AIDSVu data 100,282 PrEP users over the course of a year. And this table is called a sensitivity table, and it basically just asks, if we account, because we said we know we don't get all the prescriptions, our best guess is that we're missing 20% of them. So one thing that we can do is sort of multiply up this number that we start with to say, under different scenarios, what if we just try and, if we really want to get the best guess of the number of users, we could inflate this by the 20% of prescriptions that we think we're missing. And along the same lines, we know that some of the monotherapy prescriptions for Truvada that we observed don't have that clinical data that let us decide, was this a chronic B prescription, chronic hepatitis B prescription, or was this a PrEP prescription, or was this a PrEP prescription? So to be conservative, we just assumed that if we didn't have the data to prove that it was a PrEP indication, we didn't count it. But we know from previous analyses that when Truvada is prescribed as a single drug, as monotherapy, that 87% of the time, that's actually for PrEP. And so this just says, if our base assumption is we didn't count it if we couldn't prove it was PrEP, but what if that was 25 or 50 or 75 or the 87% that we think is the best guess, then that would be this row. So if you put those two together, if you ask me to make a best estimate based on our 2017 data of the number of people who had a PrEP prescription at some point during 2017, I would say that we could upscale this minimum estimate representing missing data and representing our best guess at the percent of PrEP monotherapy prescriptions that were probably, or of Truvada monotherapy prescriptions that were probably PrEP. And we would estimate 172,000 using those sort of best guess methods. And it's important to say that during this same, at the end of Q4, one of the other estimates that I want to mention, which is the Gilead earnings call estimates, they estimated 153,000 people having on PrEP during the Q4 of 2017. We would sort of scale up our estimate to suggest 172,000, but remember, this is during the whole year. We know some people stop and start PrEP. So it's just to say that if we adjust our purpose to say what is sort of our best guess based on the data that we have and an informed understanding of where we're missing potentially cases, we're in the same ballpark as that other estimate. In terms of future data, we will be actually. Let me just give you a couple more thoughts about the Gilead estimate, and then I'll wrap up my part. So keep in mind that AIDSVu's PrEP data presents the annual number of unique PrEP users, and the Gilead earnings estimate that people may be familiar with presents the number of unique PrEP users at a point in time. In the case of the 153,000 that I mentioned, that was in the fourth quarter of 2017. The Gilead data use different data sources. One, they're only available at the national level, and the AIDSVu data are available at the state level. The Gilead data use multiple data sources. So that includes the source healthcare analytics data that we use in AIDSVu, but they also have data from some closed healthcare systems like Kaiser and the Veterans Administration that we know we're missing in the AIDSVu estimates. And they also have data on the total number of Truvada bottles sold, which we don't have. And so therefore, they're relying on more data sources than we have. Our data are raw, as I mentioned. This 100,282 number is not adjusted for the underreporting and for the missing data on, medical indications. The Gilead data have actually been adjusted to account for known missing sources of data. It's an exercise that's like the one I've showed you here, but they presume we have a different algorithm. And then lastly, I'll just say that the AIDSVu data are meant to provide users with a consistent, comparable, replicable data set that we can reproduce over time and that we can use to understand and monitor trends and disparities. And for monitoring trends, whether things are going up and down, for monitoring disparities, which Aaron will show you, this is really pretty robust to having a known minimum estimate. So it's important to us that we put these estimates out. They are a real number of users. We understand that it is a subset, but it's a consistent subset. So I'll just end my part by saying that we are committed for this public health use to continuing to provide the most up-to-date data. Next month, we'll be releasing 2017 PrEP use data by age and race at the state and ZIP3 level publicly. We'll also be releasing data at the county level for the 2012-2017 period. And next year, we'll be releasing race ethnicity data at the state level. I understand that there's a really critical need for understanding who is taking PrEP and who is not and who needs it. And I'll say it's been our highest priority. There are a lot of additional data use agreements and quality checks, and we want to make sure that we're not compromising confidentiality in terms of the level of data that we're releasing. It is our highest priority in the PrEP data program, and we understand that it's of considerable interest given what we know about the epidemic and PrEP use, and it's coming as quickly as we can provide it. So I'll hand this over to Aaron now.
Thanks, Patrick. All right, so I want to talk a little bit about some of the data analysis that I've conducted within this AIDSVu data set to explore health disparities. So our goal here was to compare the magnitude and distribution of PrEP use in the United States at the state level. And so the analysis was conducted with our most recently available data, which is actually data from the fourth quarter of 2017. We incorporate some other data sets, including AIDSVu for HIV diagnosis and Census Bureau data. And then this paper is also published in the Annals of Epidemiology. So I wanted to talk a bit about something that we developed called the PrEP to need ratio. So the goal of this, and I'll define it in a second, is to be able to assess the provision of PrEP relative to the epidemic need for PrEP. And so Patrick earlier mentioned the traditional metric for many assessments, which is prevalence, and that is the number of PrEP prescriptions divided by the population in a given area. And so the interpretation of this is that these are PrEP prescriptions in consideration of the population size of a given area. This new metric, the PrEP to need ratio, is looking at PrEP prescriptions in consideration of new HIV diagnoses. And so the interpretation of this new ratio is the PrEP prescriptions in consideration of a proxy for need, for epidemic need, which is new HIV diagnoses in 2016. So for both of these metrics, I want to note that higher numbers mean more PrEP has been prescribed in an area, and lower numbers mean less PrEP has been prescribed. So here we have some results by region, and I want to focus first on the PrEP prevalence column. So this is PrEP users per 100,000 population. We can see the Northeast has the highest prevalence with PrEP 44 PrEP users per 100,000 population. The South and the Midwest have the lowest with 21 PrEP users per 100,000 population. So now focus on the PrEP to need ratio column. The Northeast is still the highest, and now what we're looking at is 3.3 prescriptions per new HIV diagnosis. However, what you can see is that the Midwest has 2.4 prescriptions per new HIV diagnosis, while the South has only 1 prescription per new HIV diagnosis. So this gives us a unique look at the disparity geographically that the South is facing in terms of PrEP prescriptions. Similarly, if we look at states that have adopted Medicaid expansion, so now we have a policy consideration, and below that race ethnicity consideration, which is at the state level, not the individual level. And so here, states that have adopted Medicaid have 2.4 prescriptions per new HIV diagnosis, but it's much lower among states that did not adopt Medicaid expansion 1.1. And so similarly for African-American concentration by state, we see that in states that have a lower concentration of African-Americans, there are 3.0 PrEP prescriptions per new HIV diagnosis, and this is lower, 1.5, among states with higher concentrations of African-American. I also wanted to point out there's a gender disparity that Patrick has noted as well. And here we have, and the PrEP prevalence is kind of remarkably lower. So there are 2.3 prescriptions per 100,000 population among females and 50 prescriptions per 100,000 population for males. But we know that in the United States, the epidemic is higher among men than women populations, but even in consideration of that disproportionate epidemic burden, females are still have fewer PrEP prescriptions per new HIV diagnoses than men. So we also in that paper document other disparities that youth who are less than 24 had the lowest PrEP to need ratio among age groups. States with higher numbers of residents who are uninsured had lower PrEP to need. And then states with higher numbers of residents living in poverty had lower PrEP to need. So clearly there are some substantial barriers that are really structural that are impacting PrEP uptake. So here is a map of PrEP to need ratio across the United States, and you can see it varies quite widely by state. And so I think that's important for program planning purposes. All right. So for those of you guys who love Lorenz curves, we can go to town. But for those of you who want a simple takeaway, here it is. States with the least PrEP prescribing that account for 20% of new HIV diagnoses are only getting 8% of the PrEP prescriptions. Okay, so that's 20% of new HIV diagnoses are getting 8%, areas are getting 8% of PrEP prescriptions. States with the most PrEP prescribing account for the same proportion of new HIV diagnoses, 20%, yet they're getting 43% of PrEP prescriptions. So we really see substantial variation in the prescribing of PrEP by state, which indicates the importance of thinking in terms of geography and policy when considering disparities in how PrEP is scaling up in the United States. And last, here PrEP data by time from 2012 through 2016. And these are shown by the age group on top and by region on the bottom. So we've shown that at a specific point in time, The youngest age group had the fewest PrEP prescriptions per new HIV diagnosis. Here we see the gap is getting wider over time, with that red age group, age 13 to 24, having lower estimated annual growth than other age groups. Similarly, for the southern region, there's lower estimated annual growth than other regions. So given current trends, we can expect to see the disparities that we documented in the cross-sectional, the one-time point data, actually be exacerbated over time, unless we do something about it. So, I do like to note a couple things because it's kind of a dark picture to paint when we see these really substantial disparities in how PrEP is scaling up. So PrEP's only been around, improved by FDA since 2012. So we've made substantial progress to date in getting many thousands of people on PrEP and protected. So that is encouraging. And the second thing is we have work to do. It's important to keep measuring because programs and policy changes that many at the state, local, community levels are implementing have the potential to change these observed patterns. And last, I'm going to hand it off to Patrick for a little conclusion.
I think we're really happy for this discussion about the PrEP data that we put up on AIDSVu, and I think even when we sometimes have measures that aren't perfect, it's still important to measure. I mean, as epidemiologists, this is sort of like where we live. Things that aren't measured don't change. And what we hope these data can do is help public health decision makers rely on data to determine, where we're making progress, where there are gaps, and then direct resources to areas that are sort of being underserved, whether that's a region of the country, whether that's women, whether that's racial ethnic minorities. And the AIDSVu state level PrEP data are meant to help health departments, policymakers, doctors, community leaders, advocates understand and visualize trends in PrEP use over time, so that we can develop programs and policies to increase PrEP awareness and uptake where it's needed most. And so I think it's really a great discussion to have folks who are interested in these data and maybe using them and really dig into what these data mean, what they don't, and how they're most useful. And our commitment at AIDSVu is that we think it's important to make data available, to democratize data, and to have them at the smallest possible geographic levels, because that's where advocacy and public health programs and decisions need to happen.
Wow. All right. Thank you so much for that. It was super grounding. Lots of numbers, but lots of striking data. Thank you for sharing that. Without taking up any more time or space, I'm going to hand over to Jim Pickett to really lead us in a discussion over the next 20 or so minutes about what we just heard, learned, and what's missing.
Great. Thanks you, Yamini, and thanks for it was really a great presentation, Patrick and Aaron. I would love to see this presentation every quarter. I would actually love to see it every month, but every quarter I think makes sense, right? Because it's so interesting and it's so important. All the context you put into it really helped me understand. And what really drew me to you guys when AIDSVu released the PrEP data, I was really excited about getting PrEP data that was at the state level, that was more localized. We had been dealing with mostly just national estimates, and you can only do so much with national. I wanted to know how well Illinois was doing, how well Chicago was doing. And so AIDSVu has been great in providing that. And I'm glad you mentioned, there's a big issue with not having race data. So I'm really excited to hear that race data is coming. And I'll just put out there, I think there's also data, we have data on males and females. We really need data on transgender individuals. And I want to put that out there as something that we all should really be advocating for. But excited to hear that race is coming. I think that'll be super important. And some of Aaron's slides got at the disparities, and some super interesting things came up there. But again, what drew me, one of the reasons why I reached out to Patrick and Aaron several months ago was I was noticing the difference between AIDSVu's estimations of PrEP use compared to Gilead's estimations. And there were the numbers were vastly different. Now I have a better understanding of why that is. But on the face of them, it looks like, how could they both be right? So I was really confused by that, and I'm really glad that you've given some explanation. But I wanted to loop in now my colleagues, Matt and Ife, to see what your thoughts are. You know, I actually still think that the numbers being different matter. Very few of us are having this in-depth explanation, and when the media or other community folks, they pick up the numbers that they see that are pushed out, and I think it's really confusing. But is that just me, or what? I would like to hear what Matt and Ife think about the numbers being divergent, and anything else that really struck you in the conversation. And make sure you guys unmute your mic when you do that.
So Ife, did you want to go first?
Yeah, I'm piping in. Thank you both very much. It was really great to hear that presentation live. Aaron, I was able to read the paper before we actually talked, but to actually see you sort of like talk us through the data and give us that context was really helpful. And I guess just one of the things that was sort of striking to me in terms of hearing about the data sources, and how Gilead and AIDSVu sort of captured different data sources, I think is something for us to just be sort of cognizant of when we hear this information. Just from our local experience here in the East Bay, when we were implementing our PrEP work, one of the things that was really interesting in terms of our sort of on the ground work with the CRUSH project was that at the discontinuation level of study period, so for the demonstration project that we had at the end of the 48 weeks of discontinuation, there was a lot of work that we had to do to sort of handhold those patients to transition their PrEP use if they wanted to continue to stay on. And so I see like the discontinuation data in terms of when people stop PrEP use is something that is actually really important for us to consider with regards to this, because we had patients in our clinic load that would come and pick up their prescriptions for 3 months, and then if we didn't see them for their next study visit, there was no sort of knowing whether or not they were actually still taking the medication. So just because we're counting bottles and prescriptions in terms of data does not necessarily tell us whether or not that's an active user or not. And I think that's something to be really cognizant of. The other piece that was really striking to me as well from your data is sort of the difference in sources between open and closed medical systems. And I know in our work of collaborating really closely on the ground in terms of transitioning users from study period into actively being patients in their medical systems, while we had sort of great handoff experiences with working with systems like Kaiser, we also know that is sort of something that we see policy-wise from Kaiser, that they don't necessarily share that data more broadly in terms of what's happening with patients. And so I think all of those things in terms of how these data are interpreted and then how they're used and what story they're really telling is super important in terms of reflecting on why these differences might be considered. And I really want to give a shout out to my study coordinator from the CRUSH project, because she really sort of helped me talk through some of these issues, Kristen Kennedy, when we were sort of batting around like what's the takeaway message for the East Bay. So
thanks, Ife. And Matt, do you want to jump in?
Yeah, so this is going to sound weird, so just everyone brace yourselves. I actually like both numbers. And there's a reason why. So the big number is that big, splashy, oh my God, it's working. And in a world where everyone is like, oh my God, is it working or not? Like sometimes you need to be able to show people that it's working. But I like the other number because I think it's for when you're having that more nuanced conversation for the people when you're sitting at the table with your health departments, when you're sitting at the table with your CBOs and saying, listen, they say this big number here is working, but what is actually happening in our area? And your data is the only one that's getting us that granular level. And I think that that level of data is actually extremely important as we think about this whole new era of ending the epidemic, or just even getting a hold of control on your epidemic. As Jim said, like, yeah, national data is great. And Gilead is going to tell you this big giant number for national data. But when you think that most of that data is going to be New York and California, that doesn't really help everyone in between. So it's nice that there is a data set that we know has a reliable source and where it comes from, and that data set can be continuously used and updated. What I love for the Gilead folks to, come play nicer with everyone else and share their data so that we can actually say we're in this for the public good, that would be wonderful. Do I imagine that's going to happen anytime soon? No. But I think it depends on, again, who your audience is. If you're talking to folks in your community, send them to AIDSVu because they can say, here's your zip code. Here's what's happening. But when you need to get like a rah champion to be like, no, PrEP's out there, sure, we can talk about that massive number. But I think that also one of the things, the last thing I'll say is that as we move further and further in these discussions, especially in these policy discussions, it is about the nuance and the local. Like the idea that all politics is local is so true right now. And especially in where we are at in this epidemic, it is entirely possible that everything you can get at your city, your county, your zip code is going to be infinitely more important than some big nebulous national data, because the big nebulous national data is going to allow you to obscure disparities. So I love both sets with a strong lean towards the AIDSVu data. And I love that. And I wish that we could get some better data sharing. And I lied. I had one more last thing. I'd say it's a great place for advocacy, talking about what kind of data we need state health departments to help produce and to make publicly available. And we need these hospital systems and insurance companies to also make publicly available so that we can do these big data projects.
Yes, agreed, particularly with that last point. Hear, hear.
So Ife, just a question. Do you use one or the other, or are you kind of polyamorous with your data like Matthew?
That's a really good way to put it, Jim. To be perfectly honest, we use AIDSVu more often here at the local level. It is exactly what I think Matthew sort of spoke to in terms of the ability to actually look at the more nuanced level of what's going on locally. I also do think that there's some skepticism, right, just in communities as a whole around how these data are reported and what it means and what it looks like. And just, really sort of talking more frankly and openly about the disparities questions around the data, and particularly thinking about PrEP uptake for men versus women. And it would behoove me not to bring, if I didn't bring that up, it would, I'd probably get shot in the head. But this idea that we know PrEP works, we know it's been out since 2012, and we also know that from a marketing standpoint, and from a programmatic standpoint, and from an epidemiological standpoint as well, that there was really strong push in the beginning of PrEP use to really scale up use for women, for men. And so now we're, 8 years, 6 years into, the onset of PrEP being able to be used and accessed. And we really need to think about sort of not just the disparity in the use, but just the disparity in the messaging and the disparity in the scale up, right? And so look, what I would be really curious to hear or sort of get some information on is sort of this idea of time to scale up. Like we know that from 2016 to now, we have this number of men that have been using PrEP, but and what's the number for women that's been using PrEP, and how long it actually took us to get to those numbers, and how that might influence the work that we need to think about doing to ensure that women have equal access in those same ways, right? Because there's a disparity to the scale up, right, in terms of the messaging for women, the messaging for transgender people as well, Jim, as you spoke about. So, that sort of takes us off track a little bit, but to answer your question, at the local level, the AIDSVu information is definitely more important for us to just be aware of in terms of those nuanced approaches to the data.
Thanks, and I'll play my cards. I'm definitely an AIDSVu fan because of the localization of the data. I'm really excited that it's going to include race. I think that's super important, and it was disappointing that it didn't include that in the beginning. And I applaud Aaron and Patrick and their teams for prioritizing that and making sure that happens soon. I'm really excited that it's happening in 2019. I am challenged with these different numbers. I think we can understand these nuances, but these different numbers being out there, I think is just really tricky. And I get what Matthew's saying around kind of, we need to, the bigger number or the national number is a rah-rah number or a galvanizing number. But I think it could also, it's just confusing. I mean, it confuses me. And I would like to just quickly, if I could, bring in Patrick and Aaron, if you guys want to jump in and give any commentary on as researchers, as the ultimate number nerds, right? We're all nerds, but you guys are the ultimate. How can we at the community level better message? So we're not going to be able to do an hour presentation for them or a half-hour presentation for every opportunity we have to talk about the data and talk about these different numbers. What would be the best way for us, do you guys think, to kind of hold both numbers in our hand and say they're both actually tell us an important story, and here's what that is? Do you have any advice for us?
Yeah, I can start. I just want to, I love the discussion that's happening, and I think everybody's sort of from different perspectives getting at exactly the point, which is that we can accept this limitation that the AIDSVu data are too low, and we know that, but that doesn't impact at all their ability to document disparities, to show the relative deficits of uptake in women, to show how one state's doing relative to another. It doesn't detract from that at all, because it's all sort of out in the wash, as long as we assume that the extent of that underreporting is comparable across geographic areas. One, I think that's an important point that Ife made is that this question of missing, for example, closed healthcare systems like health maintenance organizations, it's probably a really big deal in California because of the prominent role of Kaiser, Northern California, and probably less of a big deal in some other places. In terms of how we talk about this, I think it's hard because everybody wants local numbers, and I think everybody's talked to the importance of having localized data. But the truth is that right now, that what we can say, and so I want to say one thing about Gilead releasing a national number, but not smaller geographic levels, because we're concerned about this comparability between areas. It's why we go with a minimum estimate, because we can say it's a floor, and you can use it for these kind of calculations. If you're comparing sexes or states or age groups, it should wash out. However, when you do this up multiplying, if you do that, start doing it at the state level, then if there are differences in the extent to which data are missing or the indications, then you're really going to start to go farther off track. So I think, although it's not ideal, what we need to be saying to folks is it's important that we have these numbers in smaller geographic areas, and it's especially important when we want to look at trends, and we want to look at disparities, and we want to look at which groups are having better rates, are on the right trajectory, that these 13 to 24-year-olds, which for young men who have sex with men and trans women, like this is a critical age group. And so the fact that we're seeing them with a slower rate of increase, that's a real problem. And the AIDSVu numbers at the state level, at the ZIP3 level, it's a big ZIP3, fine for that with the methods that Aaron described. There's just one cell in this, all the data we'd like to have in the world piece that we don't have, which is the sort of fully inflated, not inflated, but the fully sort of upscaled best estimate number at the local level. Anybody can take the AIDSVu number at the local level. We provided the reasonable range of those sort of factors to weight up, and one can make that estimate. But I think, like, from where we are in a scientific place, we just want to be clear about what the data are and what they aren't. And when you do that at a local level, it introduces uncertainty. And so, so I think we just have to be clear of saying that, to me, the issues are sort of uptake disparities and are we getting it where we need to get it? And the AIDSVu numbers, despite their limitation of being a minimum estimate, get you to that place.
Right, and I think another way to think about this is the magnitude issue. So I think Dawn Smith in the same journal, in Annals of Epi, very recently published a paper estimating over 800,000 men who have sex with men are indicated for PrEP. And so if the absolute number is 100 or 150, we've got a long way to go. And that certainly doesn't get at, certainly we're missing big groups. You know, we can for sure say with the AIDSVu data that we're missing that some groups are getting it more than others. And so there are some areas more than others. And so I think that, the magnitude issue, if we're bumping up on the 800 number in one data set and we're at 400,000 in the other, then that's a real issue. But either way, the data indicate that there are a lot more folks who are indicated for PrEP than are on PrEP. And so I think that's like a good talking point for the overall figure. And then, I think like what Ife kind of talked about with, disparities that she's seeing, in, with women in her community. And that's the conversation I think these data sets are really intended for, is to really get that ball rolling and thinking about where do we, where are we seeing it in the community, and do the data support what we're seeing? And I think the answer is in a lot of cases, yes. And that leads us to, to kind of modes of action.
And can I just add, this is such a smart point that Erin made, and I just want to make one more point, which is if we're talking about, like, let's, to Ife's point again, if we're talking about disparities in uptake in women, one thing would be to say, like, there are 383 women who are using PrEP currently, and that number was 326 a year ago. And so that's a certain kind of information. But what Erin presented said that relative to their contribution to the epidemic, women are underserved by 80% compared to men. That sort of 0.4 to, I'm trying to remember exactly, 0.4 to 2.4. So it's like 5 times greater. So we say like women are 80% underserved relative to men in terms of their need. That's almost to me a better argument. And that argument can be made at the finer geographic levels with the data that we have. And so I love Erin's point that whether it's 100 or 150,000, compared to the number of men who needs to be served, we're way off. Are we going to do something different programmatically if we say we're serving 100 out of 800,000 or 158 out of 800,000? Like, that's a community that we need to serve better with full-on steam. We wouldn't do it, 30% less if, based on one number or another. So I think I'm trying to also figure out, it does mean a piece of, when we talk within our communities, translating to the relative PrEP to need ratio, the ratio of PrEP to need ratios is way in the wonky. But if we can translate that to say women are sort of 80% underserved relative to their, contribution to the epidemic or their burden from the epidemic, like that's a number that motivates change, I hope. And those are numbers that we can do with confidence at the local level.
Yeah, and we just and plug in for Jim as well, and for the transgender community. We know that when we see that data for that community, it's going to be that much worse, right? So I really appreciate that comment in terms of what is the action, what do we do with this? And
do we, Patrick and Erin, and then I wanted to give Matthew a chance to say some final words before we move into some other the last phase of this hangout. But what is the potential trajectory for getting transgender PrEP uptake data? I imagine it's tough. We have poor data in general on transgender individuals, but we also know that they are impacted by the epidemic in ways that dwarf everybody else. So is there a plan? Is there a thought? What are you all thinking about it? I know you don't have a lot of time to answer, but can you give us anything regarding transgender PrEP uptake data?
So I can tell you that one of the limitations is that, so the data set that AIDSVu uses is based off of other data collection systems. Mm-hmm. And part of that data collection system is pharmacy. Pharmacy data currently only collect binary gender. And so there's inherent mismatch between the data that we're reliant on and the nuance that we want and need for our programs. And so I think there, in the long term, it's important to think about novel ways to get at these data through other data sources.
And I just want to say, I was just in a discussion right before I came here with some thought leaders in surveillance where we're also wrestling with, even though CDC put in the mechanisms to capture current gender identity a decade ago, the quality of those data is still poor because it also relies on health records, as do some of the medical data that we would correlate with the prescription data. And if providers are not capturing this information, then we really have no place to go to identify it. And so what we've done on AIDSVu, and we've started to put up data from brave cities that are willing to agree to share it, is to put up the data that cities have. And every time I put them up, I put up the estimate for New York. There's 1,283 women, trans women who are reported to be living with HIV and reported as trans women. And when I share this data, somebody always says, like, I know more women than this. Like, I know that number's too low. And I say, absolutely, that's the whole point. is that we have a system that's reporting, way too few cases, and it's under-speaking to the impact in this community. So what are we going to do about that? Like, do we need more money in the surveillance system to be able to collect this? We need better training for providers so that the data are there for the surveillance system to collect. Do we need to be lobbying that, basic pharmacy data begin to include this data that are so important to understanding people's health needs, that, it comes back again to providers and EHRs, who's collecting what. And so there's nothing, I think, there's not an immediate step that we can take, but I think if some health systems are reporting it and we capture any of that, the question is, do we share it knowing that it's a 95% underestimate, because we want to have a discussion about the insufficiencies of the data so that hopefully things change about what's available to make these decisions. And I just think the more we can do that in discussion with community and discussion with stakeholders, so that we all know what we're doing here, which is, even we have extremely limited data, if we share them, then they become a starting point for discussion about how we can do better. And so I think we hear, and I take on that challenge on behalf of AIDSVu to say, we need to see what we can find, and then start to talk about where the gaps in it are.
Thank you for that, guys. And we're getting towards the end of this section. Matthew, do you have anything else you would like to add regarding this discussion we've had around data and PrEP to need ratios and disparities, et cetera?
The only thing I would add is that we need to be honest with people about what limitations we have. But when we also give limitations, we should also link that with places for future action. So, for instance, Patrick just laid out very clearly what happens with trans data, and say underreported. Here are 3 steps we know that you can do to increase trans data. And we can tell people that and give them something else to do, so that, as they say, we meet people where they're at, but we don't have to leave them there. And we can take them with us by kind of giving them options and saying, hey, this is what can happen. And that's all I'd say. Just, we can say, here are what the limitations of what we can say. We know we want to say more. We need your help. And I think we have to have conversations like this where we really get community ownership of what it means to give data, what data community wants to provide, and what agreements we're going to agree to with what we give and what we expect in return for.
Awesome. That is great. That is actually, I think, a really good segue. I'm going to pass it back to Yamini. I know there may be some questions that have come in during the chat, and we're going to potentially see what those are. Am I right?
Yes. So there are a couple questions that came in, and in the interest of time, I'm actually going to collapse those into, and I'll ask Aaron and Patrick, because they're all sort of for you both, and I'll collapse them, and then you can answer. The first is, how do you track the patients getting their medication from Canada and UK? Also, what happens if Gilead has not reached out to certain facilities such as ours for data? Another is, would you be able to provide a breakdown of PrEP users who receive supplemental coverage from the manufacturer? This info would be helpful in determining financial need in places like Texas. And then third is, would it be possible to replicate data collection similar to this at the local level, let's say at county level? How would you recommend we go about this, and what variables would be crucial?
Okay. Data. Okay. I just want to make sure I get all of these. Well, thank you for those great questions. Patrick stepped out for a bit, so I'm going to have to take over. So in terms of the question regarding how we track prescriptions from non-US sources, such as Canada, once again, we are bumping up against the limitations of the data set. That the only PrEP prescriptions that are in the database are prescriptions from the United States. And so, to the extent that that is a, that there are a number, we know there are a number of prescriptions that will come in from other sources, other countries, but we are unable to report them. At the same time, for local planning, I do think that ideally local planning programs should be strong enough that individuals shouldn't have to go, abroad. They shouldn't have to seek resources elsewhere. PrEP should be easily accessible and available. And I do think that hopefully over time, any major changes in PrEP prescription will be based on, really novel and important programs. Somewhat like what we've seen in Florida, where county health departments prescribing PrEP, really trying to scale up PrEP in areas that are otherwise underserved. I think those are the kind of initiatives we need, and those prescriptions will be tracked in the data set we have access to. In terms of, I believe there was one question on a group not being approached by Gilead. So there are kind of two data sources here. The Gilead data source, I can't fully speak to how they gather their data, but we know that they are the manufacturer and they have sales data. And so they wouldn't need to approach individual groups. In terms of the data that we use, it's actually, so it's this Source Healthcare Analytics is the organization, and they gather data at the group level for clinical practices for all manner of conditions. This is a much bigger than PrEP issue. And so I believe that group, I don't know their procedures for approaching local organizations, but I imagine if you contacted them, they're an aggregator of data. They want data, and so I think probably if you believe your clinic's not represented in their data set, you should reach out to that group and let them know, because I believe they want to, they want as wide a reach as possible. In terms of, I have a note on supplemental coverage. What's the question on supplemental coverage?
The question was, would you be able to provide a breakdown of PrEP users who receive supplemental coverage from the manufacturer? I think this question was related to the one that just came before it.
That's a good question. I'm not sure. I need to go, I think we need to go and look at it's a really important question. I'm not sure if the data set allows for that. I am quite sure the data use agreement that we currently have wouldn't allow for it, but that doesn't mean it's not a possibility for the future. The way that we've made this possible, so I mean, honestly, if you look at most disease conditions and prescribed drugs, you don't see mapping and really nuanced local data available for other conditions, completely unrelated, or other drugs unrelated. And so I think this is kind of a novel use of the Source Healthcare Analytics data set. And so it's been a process where we at AIDSVu have negotiated back and forth with that group over time, and to allow for data sharing in a way that really very carefully protects individual level data. Because if data is released at too fine an increment, there's a possibility that an individual could be identified. And so that's really of the utmost concern. So it's always a negotiation, but I think we could certainly look into the supplemental coverage issue if that exists in the data set. And if it does, whether that's something that we could, kind of try to understand the levels of. Then the last question was, what would this type of data collection look like at a local level? I do think that, especially for areas that may have a couple major prescribers of PrEP, those areas may be particularly amenable to having some kind of understanding of the PrEP prescribing at local levels. If there are 3 or 4 major clinics that kind of local activists know, these are the clinics that the bulk of individuals are probably going to, then getting data from them may be feasible. And that's the power of local action, I think, is oftentimes community will already have ties to those clinics. And again, it's going to come down to probably negotiating with those clinics about what the data are going to be used for and what parts, the exact same kind of negotiations that we've had to release and have access to these data for AIDSVu. I imagine would have to happen at a local level as well. But if it's presented as something that's going to be presented locally in large aggregate form, the local healthcare clinics, hospitals may be amenable. Interesting question.
Thank you, Aaron. We're actually out of time at this point. I'd like to just really thank Ife, Jim, Matthew, Patrick, and Aaron for really sharing your words with us, your understanding, your data, most importantly. And thanks to all for joining. Please look forward to a follow-up email with lots more information and links. A quick shout out to for our next Hangout I'd like to share with you. Next Friday, we're having a Hangout called Caring for Women Who Exchange Sex for Money, Goods, or Survival, Friday, September 28th at 11 a.m. Pacific. Look out for an email around joining us for that as well. With that, I'd like to thank you all for joining. This was Hangouts with HIVE.